Welcome to Brain Tumor Talk, a podcast brought to you by the Ivy Brain Tumor Center at Barrow Neurological Institute. This show unites leading experts, inspiring survivors, and compassionate caregivers in conversations about the latest in research and treatment. Together, we share stories filled with challenges and hope. I am your host, Michelle Palacino, a member of the Ivy Center team. My deep understanding of brain cancer comes from both my professional insights and personal experience as the daughter of a brain cancer patient. Brain Tumor Talk is your invitation to connect, learn, and find support in this community. The information shared on this podcast is for educational and informational purposes only. Nothing stated on this podcast should be considered medical advice. Welcome to Brain Tumor Talk. I'm your host, Michelle Palacino, and on today's episode, we have Dr. Yoshie Umemura. She is the Chief Medical Officer of the Ivy Brain Tumor Center and Division Chief of Neuro-Oncology at Barrow Neurological Institute. Today, we're talking about everything from standard of care to clinical trials and the role they play in a patient's treatment plan. Dr. Umemura, thank you so much for being here.
Thank you for having me, Michelle.
Okay, so let's dive right in and talk about your roles at the Ivy Brain Tumor Center and then your roles at Barrow Neurological Institute.
Sure. So those are a lot of titles.
Mm-hmm. Yeah, it is a lot of titles. It's extremely impressive. Yeah.
It's a lot of titles, but really the bottom line is I'm a neuro-oncologist. Mm-hmm. I treat adults with brain tumors or people who have neurological problems due to cancers. I'm a neurologist. And my role at Barrow Neurological Institute is that I lead the neuro-oncology program, not like the surgeons and radiation, but neuro-oncology program. And that's the division chief part. And as you know, Barrow, we have Ivy Brain Tumor Center where we conduct clinical research, brain tumor related research, and I'm chief medical officer for the Brain Tumor Center. And what that means is that, I oversee medical decisions that we do. So for example, if we do clinical trials, not just one trial, not just my trial or someone else's trial, overall, does it make sense medically? Are there any medical concerns, toxicity concerns? I would advise, our principal investigators, directors, and so I kind of dip into all of those aspects.
Mm-hmm. You're a jack of all trades, I feel like. You really are. So what is the difference between a neuro-oncologist and a general oncologist? Because I'm sure a lot of patients are seeing just, your normal oncologist, and I don't think anybody's ever really said, there's a difference.
Mm-hmm. So I think, I'm a neurologist, so I think a lot of us would specifically say, we're neuro-oncologists because we're not, general medical oncologists. We don't treat any other cancer necessarily. It's not to say they're like normal or less or more. It's just the specialty is different. There are some neuro-oncologists, meaning oncologists who specialize in brain tumors that are not neurologists, that are come from medical oncology background. You can go in from either. But when we say neuro-oncologist in general, it encompasses both medical oncologists who specialize in neuro-oncology or neurologists who decided not just migraines and strokes, but also really want to focus in brain tumor care. And you can go from both direction into that subspecialty.
So for a patient that's just been diagnosed with a glioblastoma or any kind of brain cancer, or really any kind of, I guess we can even go even broader in any kind of like neurological issue, how important is it for them to seek out somebody who specializes in these neuro issues? So I think patients are very savvy nowadays. A lot of times we don't need to tell them who they need to see, and they find all the specialists. Sometimes they might see more people than they may really need. Mm-hmm. I do think having an opinion from a specialist who eat and breathe and sleep and dream the disease that you are diagnosed with at least one time and get the opinion of overall care, I think that does add a lot of value. When someone is diagnosed with a tumor or cancer diagnosis that does not have a cure, I think being able to enroll in a clinical trial may mean different outcome for people. Mm-hmm. And those doors open when you see a specialist. Mm-hmm. There are a lot of community centers that also have clinical trials, but I think just discussing these different doctors that are available with anyone they see, I think that's the important part rather than like, do you have to go into a brain tumor center, Mm-hmm.
I think the best that people get a lot of time is that if their doctors collaborate with the other doctors, not so much like that one single doctor, right? So, and also it's not realistic for everyone to have a neuro-oncologist at their finger point. You know, there's not that many of us. And also a lot of medical oncologists who do not specialize in different disease, they're all fantastic oncologists, and they are well-versed in brain tumor care too. But what we often do is patients might see a medical oncologist, and they may also routinely every few months see a neuro-oncologist to just have a wider net of treatment team.
Yeah. You know, you just said you sleep, breathe, eat, dream, all brain cancer. And you really do. Like, you are so involved in the patient experience and the care that patients, you really care, you know? And I'm curious as to how you got involved in neuro-oncology. Like, what inspired you to do this profession?
So I think I'm a minority at Ivy Brain Tumor Center, or at Barrow. You know, I'm very inspired by my colleagues and people we work with, and see that they have inspiring stories about their personal life, their family members, mother, father, cousins, aunt, sister who's had brain tumor. I don't have a personal story like that. For me, I was intrigued by the brain initially. I went into neurology because I'm fascinated by the brain. And as I was deciding what I wanted to do within neurology, I was really drawn by the patients who had diseases that we treat in neuro-oncology clinic. And I essentially ended up following them into the neuro-oncology clinic as a subspecialty training. Initially, I wasn't actually interested in tumor treatment. It was really the cancer-related neurological problems that fascinated me, how the body reacts to cancer and neurological issues that you get. I'm a neurologist. But as I trained at where I did my fellowship, every day I just learned more and more from patients and their family. And essentially majority of patients we saw were patients with glioblastomas or deadly brain tumor. And day in and day out, you give news, bad news, good news. They partner with you. You see them so often. They let you become truly part of their team. And a lot of the common things that we talk about in these clinic visits is they often say, are you doing anything about finding a better treatment? And I think over time, I just really felt that I wanted to do more in that realm. And that really got me into clinical trial development. And that's what I ended up pursuing as a career. So very, very just whatever that happened, one thing led to another. I don't have like a one big inspiring story to tell you.
Yeah.
Yeah.
Well, I mean, your story at Barrow is inspiring. You know, like, you do inspire all of your patients that come in. You make the experience really exceptional. So I do want to say that, because you are an exceptional physician.
Thank you.
So we kind of talked a little bit about clinical trials, and I do want to revisit that. But for the listeners that are just listening in and they've just been diagnosed or they've recently had a recurrence, can you talk about the standard of care that those brain tumor patients are getting into? Because you kind of mentioned that, like, you know, the treatment, but I don't think a lot of patients who've just been diagnosed even know, like, what that treatment is.
Yeah. When patients are diagnosed with brain tumor, I mean, I have to touch upon that the most common brain tumor is a metastatic disease from other cancer or brain cancer. The most common brain cancer is a brain metastasis. So the right treatment oftentimes is what makes sense to treat, their breast cancer or lung cancer. But since we are focusing on primary brain tumor, meaning the things I think Dr. Sanai touched upon the difference, but the primary brain tumor that originate in the nervous system, oftentimes the first approach is surgery. And most of what we treat is not curable with surgery unless we're talking about some slower growing things that are brain adjacent, something called meningioma. Those can be just one surgery, you cut it out and you're done oftentimes. But I think the tumors that we really think about in these clinical trials are problematic tumors like glioblastoma or astrocytoma, oligodendroglioma, CNS lymphoma. There's all these tumors and cancers that is not curable with our standard. And in those diseases, oftentimes there's a first-line surgery that happens. Most of the time we try to take as much as you can without hurting the patient, because that's not cure. And then you follow that with either radiation alone or radiation with chemotherapy, depending on the disease and what makes sense. For glioblastoma, which is the most common brain malignancy in adult, we tend to do maximal safe resection, followed by radiation with combination with chemotherapy, followed by chemotherapy. It adds time, but I think we really want to focus on quality of life as well. And it just isn't good enough. And that's where clinical trials come in.
Now, what are the chemotherapy options that are currently available for brain tumor patients? I think most people have heard of temozolomide or Avastin. And can you kind of talk about the difference between those two treatment options and why certain chemotherapies are used?
Sure. I think temozolomide is the most common drug that people hear when people get brain tumor. Temozolomide is a medication in a class called alkylating agent. And what it does is it's essentially a medication that causes DNA damage. It causes cell damage, and we want to kill the tumors, right? Just like radiation. Temozolomide can make radiation work more, better, so to speak. Makes cells more sensitive to damages from radiation. But also on its own, it's an alkylating agent, meaning it causes double-strand DNA damage. And that in turn will damage the cells. That treatment doesn't work as good as we want it to because tumors can repair itself. So it can work to a certain extent, but the tumors eventually then start growing again. Avastin, which is a brand name, or the generic name is bevacizumab, which I think a lot of trainees have to practice saying.
Yeah, I would not be able to say it if you asked me to.
Whenever I say it to the patients are like, wait, what?
Yeah.
So bevacizumab, or there are other biosimilar bevacizumab dash multiple alphabets usually.
Yeah.
So bevacizumab is a different type of medication. It's considered chemotherapy as in terms of like tumor-directed treatment, but it's not chemotherapy in a way traditional, what we think of chemo as like cell-damaging type of medication. It targets the growth factor of blood vessels and endothelial cells. So essentially, these tumors cause so much disruption in blood-brain barrier. So when you get an MRI of the brain or CAT scan, we inject IV contrast. That IV contrast normally is not supposed to get taken up by a normal brain. But because there's a blood-brain barrier, it's a bigger molecule. But when you have disruption from whatever is going on, whether it be stroke, hemorrhage, infection, abscess, injury, inflammation, or aggressive tumor, things that can disrupt that barrier, it causes the contrast to going. A lot of times aggressive brain tumors is enhancing, it lights up on the MRI because the contrast is getting in. It's just a sign of what is happening behind the scenes, right? So by giving Avastin or bevacizumab that kind of shuts all of the abnormalities down, it reduces, I don't want to say it shrinks the tumor. Sometimes like we say that. I mean, it does, or visually, we're not necessarily saying the tumors are gone. It's really reducing the tumor disease burden. It's
So
not
kind of like reducing the swelling.
Well, it's not. The swelling is it's a result of that burden. So it's it's making it less angry and problematic, and you can coexist a little better.
Yeah. So what would be the difference between the Avastin and then the steroid? Like the effects of both of those two.
Yeah. So I've toyed with so many different analogies. I tend to go to like acne analogies just because people know what skin looks like. One of my patients pointed out, like, you always talk about acne. I'm like, because everyone knows. So I'm going to try a different one. Okay. Because I feel like I'm
ready for the analogy.
Because the acne is kind of gross. So imagine you have a rock, which is a tumor, and it's really hot, just piping hot. It's smoking hot, just like the lava rock, right? So that's the inflammation, let's just say. You have all these steam coming out. and then that's the swelling. You're trying to cool it down by blowing on it, fanning on it from afar. Imagine that being the steroid, and Avastin is pouring water on that rock.
Okay. Yeah.
I don't know if that did anything. So steroid is trying to contain the inflammation.
Yeah. No.
But not so much like addressing what's causing the inflammation.
Right. And then the Avastin is addressing what's causing
Avastin can address that. What's the bottom line? What's causing inflammation is a tumor or either tumor growth or sometimes treatment-related inflammation or just necrosis, meaning like dead cells. When cells die because we want it to die when we're treating, your brain doesn't like dead cells. Brain doesn't like dead things in there.
Yeah.
So it's going to cause inflammation.
Yeah.
But inflammation can cause symptoms.
Yeah. So all of these would be considered conventional options, right? Like
Correct.
all of these things would be kind of your conventional treatments. So for the patients that have maybe gone through these conventional options, or they've done genetic testing or mutation testing and they found that, maybe they're unmethylated and they're not as responsive to these conventional treatments. How do you approach these conversations of the unconventional treatments? So maybe like clinical trials and we'll start with that question.
Sure. Okay. Let me unpack that. So I think...
Yeah, it was a loaded question.
That's okay. So I think the conversation has to happen from the beginning, right? We're kind of giving people an overview before we give them a detailed roadmap, right? When you go to Disneyland, they don't just like take you on a tour right away. They tell you what Disneyland is, and then they might give you a map and recommend what rides to take first. So when you come in to talk about brain tumor, I think talking about overall what we're dealing with is very important. And then, of course, I'll talk about standard of care, but if the standard of care is really not good enough, it doesn't offer a lot like a cure or even a meaningful extension of life, I usually tell them then, are there options? What are the other things that we can do? Of course, one extreme is doing nothing. I oftentimes don't recommend that if people are doing okay after surgery. But there's a lot in between. First line, like right after they're diagnosed, I do not recommend kind of going too far away from standard unless it's clinical trial. But even in standard of care, after that first line treatment, bevacizumab is not necessarily going to extend life most of the time. Our specialty is essentially giving chemotherapy that is off-label, right? So that's not clinical trial. So we often talk about non-standard of care standard options, but we also know those second line non-standard standard options come from previous clinical trials or things that were a good idea at one point, but didn't necessarily get good enough to be first line. So if we're going there, then why don't we try something that also has potential good idea, but hasn't really proven to fail?
Yeah.
Right. That's kind of the idea of clinical trial, in my opinion. I tell my patients clinical trials are like lottery tickets. You've probably heard me say that.
Yeah, I have heard you say that
a few times.
Yeah.
As someone who conducts design and conduct clinical trial, I hope all these clinical trial pan out. But I think realistically, we all know getting a very positive clinical trial is hard, right? A lot of clinical trials fail. It's not going to stop us, but it does make us think harder each time to try not to fail again, or at least make adjustment to improve so we have higher chance of succeeding, right?
Right.
But most of these clinical trials do not succeed. So I'm not going to tell my patient, you have to be on a clinical trial if you want to live. That would be a faulty thing to say, right? Most of the people who buy lottery ticket do not win, right? Or maybe they might win $15,
right,
$20, $100,
right,
but not everyone wins $1 million.
Right.
But there's gonna be one day that lottery is gonna be a high chance lottery.
Yeah. Yeah, and I would hope that one day, I don't think a lot of the patients that are listening to this are thinking like they're going to win the jackpot. I think that like even if you get an extra 6 months, an extra year, an extra 5 years, it's priceless, like absolutely.
Yeah.
It's just
so
invaluable.
I think that's actually interesting that you said priceless. So the reason I bring up lottery ticket is because I also mentioned is it $1 lottery ticket? Is it $100 lottery ticket? It's different, right?
Yeah.
So the cost of entering a clinical trial, being in a clinical trial, it's not the money. The cost is what it takes away from your life.
Right.
So if it doesn't take a lot away, maybe it doesn't cost a lot, right? But what if a clinical trial require you to be hospitalized for a month, or you have to go to an infusion every week? Those are all, in my mind, cost of being in a trial, right? And is it worth it? Is it not worth it? I think that's very personal question, patient to patient. And I try to help them kind of arrive at a conclusion, but I do caution people from like chasing a trial very far away from home, you know, and then make sure they understand what they're testing, because some clinical trials may not really be looking at even efficacy, right? And then these are very important. I think it's important conversation from investigator to physician to the patient.
Right.
And I try my hardest to separate myself as a clinician and investigator when I have these conversations with my patients.
Right. And I do think that you do a really great job of not putting in kind of like your own self-interest and kind of speaking from like the perspective of what a patient's family member would want. And so do you feel that a lot of patients understand that the standard of care isn't curative when you first have those initial conversations with them? Do you feel like that they're understanding that, like, you know, conventional options are not going to work? We're going to need a second line of defense? Because I feel like a lot of patients and families, they want to fight. You know, they have purpose and they want to achieve the goals that they've set out to achieve.
I hope my patients do get that. You know, I don't need them to remember every single thing I say in the room, but there are a few things that's non-negotiable. You know, because for their sake, right? I don't mind repeating things over and over, but it just pains me to see someone be pushed off emotional cliff each time they see me, right? So there are certain things I want to make sure that we're on the same page of. So the things that I absolutely will correct is if they feel that we're going to fight this. That's actually a term I usually try to take more time talking about, because what are we fighting for? Are we fighting to be immortal? Because I can't win that battle.
Right. I can't either.
Exactly. I know. I can't win a battle over wrinkles. Yeah. Right. So, but are we fighting a battle to extend someone's life and quality of, so there's like multiple battles, right? So when someone, of course, like mentions that's my time to kind of go in and talk about, let's define what battles we're going to be fighting, right? Because there are going to be battles that we're absolutely not going to like even entertain losing, which is someone's quality of life, in my opinion.
Right.
Of course, everyone's different. Some people may want to sacrifice and then that's everyone's personal choice. And I respect that. This is a free country. And I knew that when I moved here. So, so I would say, so these are conversations that I try to spend a really good chunk of time talking about. Sometimes even more time I spend talking about that than like actual treatment, because it's important for me to understand it's so hard, right? It's like going on a date. You're not going to find everything out on the first day.
Yep.
And as a non-procedurist, I'm a neuro-oncologist who does not operate or do radiation. My role is to really be their biggest advocate and clinician for the remainder of their life, usually. And I can't help them if I don't know what they want.
Right.
And I usually spend a lot of time trying to find out more and more about the patient.
So is that how you would define quality of life? It's really on a patient-to-patient basis? Or is there kind of a universal standard that you hold true to every patient when you're having these conversations about quality of life?
Now we're getting to like morality of like tenet of like what is quality. I think there's certain things that is like easy. No one likes to be force-fed. No one wants to, they want their autonomy. So those are the easy ones. The hard ones are, I remember when I was an early in training in neurology, I remember this vividly. I was on call as a neurologist. I was, I think, first year in neurology training. I took care of this gentleman with stroke. He was in ICU because when someone has a massive stroke, you get into the ICU to be monitored closely. He wasn't dying. He was going to recover. He needed rehab. Immediately, I was called into a big family meeting, and a family told me that they wanted to pull a plug because the patient would not want to live if he couldn't do his own plumbing. It was really eye-opening to me that there was that. And then literally in the same month, I had a patient that I kept advocating that someone should be made comfort only, essentially pull the plug. And they said, doesn't matter how the patient was, if she was taking a breath, even by machine, it mattered to them.
Yeah.
I don't have to agree or disagree with any of them. My job is to provide the best medical care and advice.
Yeah.
And I just saw like polar opposite, right?
Right.
Most people are somewhere in between.
Right. Yeah.
But quality of life means, are they having enjoyment? Are they are they miserable, essentially, right? Do you want to be kept alive in certain state? And obviously you don't want to ask someone that like when they're immediately told a brain tumor diagnosis.
Right.
This is something, yeah, exactly. So it's not black or white. It's such a huge shades of gray.
Okay, so we talked about how we use the analogy with clinical trials being a lottery ticket. Can you talk about the cost of participating in a clinical trial and really, some misconceptions about it? What's involved? How do you approach patients in the conversation about what's involved in a clinical trial?
So when I start talking about clinical trial, I will tell them kind of what we talked about, not in that much of a length, but just the idea of what clinical trial is, which is an idea of something better, and what you have to consider are these extra visits. And I'll also consider which trial we're talking about. I'm not going to talk about every single trial, right? I'm only going to talk about trial that we can consider. So we'll talk about in general, is it going to be a weekly visit? Is it a monthly visit? In general, if you're not on the clinical trial, are you going to have to come in as often? How much more often? Are there going to be switch of a medication or addition of medication? What are the anticipated risks of side effects that you can anticipate? Is it more or less? So we try to talk about those things before ever considering a clinical trial. I do also recognize that conversation does take a long time. I warn my patients that I might run late occasionally or sometimes. And when I do, it's because I'm doing that with another patient. And most of my patients are very understanding. But I'm also blessed to have the type of clinic that I can do that. And not every doctor have a clinic like that. And so if I also offer patients, if they see other doctors or if they see an information and they want to look at it from a non-layman's perspective, I do let them know to just get me the clinicaltrial.gov number so I can look up the information, ask around, and think up those options with them if it's not a clinical trial that I have.
Yeah, you just made me think of a point about how, you are very savvy when it comes to being connected in the neuro-oncology world, and you do have a lot of access to the clinical trials and what's available, what's promising. So for the patients who don't even know where to start, right? We've all been on clinicaltrials.gov, and it's just a rabbit hole of, medical jargon or, undecipherable for the average person who's going through this. So how do you, or what advice would you give to the patients on where to even start when looking at a clinical trial?
Use your doctors as your resource, right? There's no way you're going to just scour the internet and go down clinicaltrial.gov or read up to date or get a textbook and just know exactly what to do. It's not. And also, just because a clinical trial is open that you should enroll, it doesn't mean that way. And I think, I'm very thankful that my patients throughout my training have taught me the partnership of being a physician and the patient, that relationship that I have developed over the years. Let your doctors know that you want them involved in, the easy things if I'm your mom, what would you want me to do? Those are common question, but I would tell them I would have a conversation with my mom and also my mom. It took me 10 years to convince her to take a cholesterol medication, right? So I don't know if they were my mother, if they will even listen to me.
Right.
But I do think the relationship you have with your doctor will be important. to see if you can, trust is a funny word, but if you can trust what your doctor is saying. And I think that's earned. When I first meet a patient, when they say, sometimes you get these grumpy patient occasionally, and like, why wouldn't they be?
Right. I was going to say, rightfully so.
Exactly.
I feel like
exactly.
Our patients are so amazing. They're like the best
they're
people.
amazing. And occasionally someone's grumpy, and it's okay.
Yeah.
I'll take that, right? Yeah. But when they are grumpy and they say, why should I trust you? Why should I believe you? I usually tell them to not. I say, don't trust me. Don't believe me. Make me earn it, right? I'll be here to give you all the information. I want you to feel that you can trust my opinion. And if you don't feel that way, then I haven't earned it. I'm not going to tell them to trust me, right? So I do think it's important for, and perhaps some people won't, right? I'm going to do my best, but it's a human to human relationship. We're not machines, right? You can't customize me to be someone else. And I'm going to do my best to accommodate everyone I see. And I don't treat everybody the same way, like a cookie cutter. But maybe it won't work out, right? But I do hope that patients can find a team that they feel comfortable having a conversation, so they don't have to stay up all night scrolling the internet to feel like they made the right decision. They can talk to someone and they feel like someone has done the homework for them.
Yeah, I think that's a good point. And I think one thing that might help patients establish that level of trust with their physician is, asking the right questions. So what kind of questions would you advise patients ask their physician when approaching this disease in general? Like, what questions should they ask when approaching the conventional treatments, and then including like the unconventional treatments too?
I think the question they absolutely should ask is what kind of side effect they would expect, what kind of toxicities, if they're talking about surgery, what kind of deficit they can't, not just expect, especially for surgery, because that's not really reversible. You can't put the brain back. So, what are the maybe not so expected but possible things, and are you okay with that risk? Because it will be too late once it happens, right? So I think those are absolutely things people should ask. Now, everything else, though, it kind of depends on what you're thinking. I think people should definitely write things down. Go to a dollar store, or not a dollar store, go to a stationery store and get a cute one that you will hold on to. Get a notebook, write things down. Something comes up, put it on the phone. I do think any question is a good question. If your doctor make you feel stupid, then tell them that they're doing that, right? And because they shouldn't. And if you let them know, they're probably going to be mortified and do it differently. I think all questions should be answered with respect. And if you have it, it's a good question. And if you haven't asked it and you're worried that, like, what if I haven't asked the right question, or I haven't asked all the questions, don't worry about it. You're going to see your doctor so often.
Right. So going back to kind of like the basics, when, it's a question that I was actually thinking about, and I think a lot of patients see it, is these early phase clinical trials. I think most people are familiar with what a 1, 2, and 3 is, but I'm still going to ask you to define a 1, 2, and 3. But what are the early phase clinical trials?
So early, some people would say really anything that's not 3.
True.
So I would say, so I can define, phase 3 clinical trial, I think, is a clinical trial when people think of clinical trial. During COVID, and, people think of clinical trial as a testing of experimental drug compared to sugar pills, and you randomize it or blind it. Those are actually most of the time phase 3. It's not always. You can get that with phase 2. So essentially these phases are in phases to answer a question. And then the bottom line question that everyone wants to know most of the time is it going to work? And then does it work better than what's existing? The comparison usually happen more robustly at a phase 3 setting when you compare to sometimes a standard of care or two competing trial ideas. So that's, and how you define phases, that's also like statistical power and things like that. But to simplify it, does something work better than the other? That's phase 3, let's just say. All right.
Yep.
And then phase 2 is a step before. So before we take on this big, gigantic trial to compare to, you may want to know, but do we think it actually does anything? Is it actually efficacious? And to get signal for that, you can do phase 2, which may not be comparing to another arm, but you're saying like, okay, if this works, we think someone should live for this long. So you can test that theory. And oftentimes phase 2 can be non-randomizing, non-comparing. Of course, it would be more robust trial if you are randomizing and comparing. So that's why I say 2 and 3 can be similar. Some trials are 2/3, so you do kind of a combined approach. So 2 is still considered early phase if it's earlier than 3. Phase 1, the easy way to think of it is more of like what dose, what safety, like what's the right way to do the phase 2. So oftentimes the main question for phase 1 is how high of a dose can we go in that specific condition that we're treating or in the combination, and what kind of toxicity does one do, or maybe like do we want to do it once a week, twice a week? So it's more of a dosing safety question most of the time. And then if we go outside of that, we kind of start making up how we call it, right? Mm-hmm. We agree on how we call it, but it's not phase 1 through 3. Now we're talking about pilot study, phase 0 study, window of opportunity study. And there are definitions of why we call one window of opportunity or phase 0. So those are like super early before phase 1 studies. And those studies often involve surgery, not because surgery is the treatment, but oftentimes we're trying to understand things more at the molecular cellular tissue level, not just did you have nausea, how long did you live? You want to know whatever we're saying that should happen in the cellular level, which is usually studied in tumor cells on a petri dish or in animals, right? And then even though that's what we do, right, mice brain and human brain are different. Dog brains are different. Pig brains are different, right? So things that we think should be happening may not be happening in the human brain, right? So to answer those questions, oftentimes we need that surgical aspect to get the tissue, and you may give drug before either a designed trial time point surgery or someone's going to have surgery anyway, which is the more common way to do it. We give them a drug, and either for therapeutic purposes or for investigational purposes. And you might get an answer of how much drug is getting in, how quickly does the drug get in. So those are called pharmacokinetics, and pharmacodynamic, PK/PD, is more of like, is it doing what we want it to do type of thing? And we look at that in more of a scientific level. So those like the very early stuff. And at Ivy Brain Tumor Center, we do things that is very unique. That's not just, so a lot of times people might have phase 0/1, but really they're separate within the same like umbrella, but we're doing phase 0 and we're doing phase 1, right? Answering very important questions. But oftentimes these phase 0 patients, what about the therapy, right? Like, is it working for them? And answering that in separate population. So the platform that we have that's very unique is you're combining that within a patient, not just within a study. We try to answer that question at an individual level. Is a drug getting in? Is a drug not getting in? And only if so, then we offer them to go on to the phase 1 or phase 2 to answer the rest of the questions. I think it's quite robust because you can then get a better answer at that phase 1 or 2 selectively in patients who we know the drug got in.
Right. I mean, that was very extensive, and I do think that a lot of people. No, I appreciate it, and I'm sure our listeners appreciate it too. And I'm sure that when our patients are going through clinicaltrials.gov, they are seeing all these different phases of studies. And I will say, I feel like most people feel the more options they have with this disease, the better, right? The more doors that are open, the more opportunities that they have, the better. Is there ever a time that comes that you've seen with your patients where there's just no options left?
Yes.
And then I think the challenge here is that our patients want to keep fighting, right? Mm-hmm. So what's the conversation look like when we've run out of options, but the fight still wants to go on?
So I think you and I needed to have that conversation about fight, right?
Mm-hmm. Yeah.
I think so. In that sentence, I'm going to replace fight as the patient wants to keep treating the tumor rather than fight, because I do think there's still people are going to have a fight left in them for a lot of things. That's not tumor treatment, right? Still fight in them to make sure they enjoy the hell out of the next day with their daughter or whatever, right? So if we're talking about patients who don't want to hear that there's no other treatment I can offer them, I don't usually just spring that on them. I will tell them, right now we have these options. A lot of times I can't offer a clinical trial. A lot of clinical trials are really focused on glioblastoma. I treat other tumors. My dream would be to have a clinical trial option for any patient that I don't have a good option for. We're not there yet. But even in glioblastoma, if they're not candidate for a certain trial, I can't offer that. But I do let them know that, non-trial wise, I think we could try this or try this or try this. I also take time to talk about if I expect their functional status, like how they're doing day to day, to improve or stay status quo or lessen based on the treatment, because if the toxicity is really bad, their quality might be worse, right? I think laying out all the options and telling them what I think, which one is priority, and making sure that partnership is there in the conversation. Usually me saying like, there's no more option is not like something I just spring on them. And a lot of times we're already on the same page.
And then, I do have to ask, from your perspective, what do you find to be the most promising treatment on the horizon, right? I do feel like everybody's on the precipice of a cure when you go to all these other conferences and these organizations. So what do you find to be the most promising?
I think from the PR perspective, a lot of people say that everyone is on the precipice of cure.
It seems that way when you're looking at these other institutions and you're on their websites, right? It seems like there's so many options available, but then when it actually comes down to it, you realize it's actually very...
Right. I don't think any, neuro-oncologists or people who, like myself or doctors and I don't think if you talk to trialists, anyone would say like, we're really close to a cure. Yeah. I don't think anyone would say that. I think it's important for people to get the attention, and there's certain messages that may get thrown that way. As a chief medical officer, I'm very careful with those messaging on our materials, right? We don't want to overpromise.
Right.
We don't want to be over negative.
Right.
But it needs to be right. I think we're definitely not there because we're still trying to figure out how can we get even extension more than just few months,
right?
Few years. That would be even 6 months improvement is going to be groundbreaking, which is very sad to say. But that's where we're at, realistically. So if you tell me what's the most promising, it's really hard for me to answer. I think the key is going to come down to if we can get investigators to collaborate better. The way science is done, I think there's a lot of issues with how fundings work, how the scientists have to compete with each other for certain funding. It creates silos. Essentially, we're competing with this incredibly smart, aggressive tumor, and we can't do it with just one institution alone or one investigator alone. And I think when I see people collaborating with different institutions without playing games, and because these are people's livelihood too,
right?
I think that's where the most promising things happen and things work quickly, right? And I think at the Ivy Brain Tumor Center, we've taken a lot of that walls away, where scientists and the non-scientists and clinicians, we all sit together and talk about what we all want to do in the project together, rather than, but this is my science, this is my science. And I think that is the most promising things that I can see, and that can lead to a drug. I'm hesitant to say it's going to be immunotherapy, it's going to be targeted therapy. I don't think you can say that. It's probably not going to be a one thing.
Okay, and then I have one more question for you, and we'll do our little rapid fire.
Sure.
Knowing the realities of this disease, what do you find to be the most rewarding part of your job? Like, what keeps you positive?
When my patients tell me something and they smile and laugh and they truly seem happy, because knowing, my clinic, the doors is neuro-oncology, and my last work where I used to work before I came here was cancer center. Mm-hmm. And as a patient walking in there, it's already a downer, right? You're not walking into Krispy Kreme.
Like, nobody's excited.
No one is excited to come see me.
Right.
But when they come see me and I walk in, I try to get things out of the way by saying, your MRI looks good. And then talking about what they did for the past 4 or 8 weeks I haven't seen. They're telling me that they got to do this, that, and that, and they're sharing their life story and sharing those stories with me. That's the most rewarding for me, because I know that I did my job right, so they can actually relax and talk about these things, and they're actually going to enjoy their life. That, to me, is very rewarding.
Well, thank you so much. So I do want to end this episode with one thing. It's kind of like how we're ending each episode. We always hear the expression 1 day at a time or 1 minute at a time. Taking things 1 second at a time. And so I'm hoping to do a quick fire with you of kind of like your one idea or choice or thing that holds significance to you.
Okay.
Are you ready?
Okay.
Okay, here we go. So what's one piece of advice you would give to your younger self?
I would tell myself that things will work out and you can just do whatever you feel like doing.
What's one thing that people would be surprised to learn about you?
That I did not know how to speak English until I was 16.
What's one thing you do to de-stress?
I sniff my dog aggressively.
What's one habit you'd like to break?
I need to drink more water.
What's one book you'd recommend everyone reads?
Kiss Your Brain by Christina Costa.
What's one thing you're most proud of?
My mother.
What if you weren't a neuro-oncologist, one profession you'd want to try?
Indiana Jones or a travel concierge.
And then what's one thing you'd want to be remembered for?
That I lived a full life.
Well, Dr. Umemura, thank you so much for coming on Brain Tumor Talk today. I'm sure it was extremely informative. I found it super informative, so thank you for taking the time today.
Thank you so much, Michelle.
We hope this episode has informed and inspired you. Subscribe to Brain Tumor Talk so you don't miss another episode, and please consider leaving us a review to help others in the brain tumor community find us.